Okay, well, I think to respect everyone's time, I see that people will still keep trickling in, but I think it's appropriate for us to get started. And excuse me while I fidget with some stuff behind the scenes. But thank you everybody for being here tonight. My name is Ruben Sanon. I'm one of the deputy mayors here in Mayor Rose Conway's office. And I'm one of them who've been working most closely with CARES in this office. I got to work alongside some of our staff, including Chase Stedman in the fire department, who you meet from tonight, staff from Journey Mental Health, another one who you meet tonight, as well as people from the county and people from public health. Tonight, we're going to delve into the findings from a report detailing lessons learned and impact of 1 year of CARES in operation, give you insight into the future of CARES, and then provide time for Q&A. The report documents findings for up to 1 year of the anniversary that ended in September, and can be found in the link that you did your registration with, and will also be shared with participants after the end of our meeting tonight. It will also be shared on my pages where CARES can be found. So if we go to the next slide. So I wanted to share our agenda with you tonight. After this, we're going to go into some welcome and introductions. We have the mayor here tonight to share some remarks. Then we're going to go into an overview of CARES, led by Assistant Chief Chase Stedman. And then we'll have that question and answer period and hope to wrap up by 7:30 tonight. So I'm going to invite, and actually before we go into that, I'm going to show you how to participate. So yes, next slide, please. So I haven't mentioned this, but this is being recorded. This is also being streamed live. You can find us on YouTube and other channels. Attendees will be muted, but we encourage you to use the chat option if you're having technical difficulties, and to use the Q&A option for asking questions for that Q&A period at the end. And I'm going to go through a couple of slides to help it make more clear with some pictures about how to do that. Next slide, please. So make sure you're joined with audio. At the bottom, it says join audio in little letters, and then it says join audio by computer. Next slide. And again, if you want to have help with some technical difficulties, use that chat option. We'll be able to see it up here. And then next slide. The Q&A option that will be stacked questions for us to address at the end. Our person who's helping us with that is Kara Kratowitz, and she's going to try to, if there's questions that are similar to each other, answer them all together, and try not to answer the same question several times. And then we're going to, like I said, try to wrap all of those up by 7:30 tonight. Next slide. So what I'm going to do now is move into introductions of our staff. And I'm going to put it on review so that everyone can see everybody. So tonight we have Kara Kratowitz. If you want to turn on your camera, she's the Performance Excellence Specialist, City of Madison Human Resources. She's going to be supporting us and answering that Q&A questions, and she's been part of this process a little bit in the last few days. Then we also have Chase Stedman. He's our Assistant Chief. Like I mentioned, he is going to talk about the aspects of the program, like I talked about, and some of those findings using the fire department. Sarah Henriksen, Clinical Team Manager from Journey Mental Health. And then you already know me, Ruben Sanon, Deputy Mayor. And now I'm going to invite Mayor Satya Rose Conway to speak and give us some opening remarks about CARES tonight. So I will pass over to Mayor Satya Rose Conway.
Great. Thank you, Ruben. And thanks everybody for being here tonight. Really great to see folks interested in the CARES program and our report. From the beginning of this journey, my office and the Madison Fire Department worked really closely together to examine data, connect with national experts, and tap into the knowledge of folks in our community to build the Madison CARES into the program that it is today. Our goal was to deliver an urgently needed, patient-centered services and to divert nonviolent calls for service from hospitals and from the police department. And after identifying the time of day and geographic locations with the highest need and where we might be able to achieve the most impact, we launched CARES in September of 2021 out of Fire Station 3 on Willie Street. And it was in service from 11 a.m. to 7 p.m. Monday through Friday, with a focus just on the downtown Madison area. We launched in the middle of a pandemic, but we did that because the need for mental health services was rising, in part due to the pandemic. And when we launched, our mental health landscape got a little bit stronger, a little bit more availability of service. By December of that year, we discovered that we had the capacity to take more calls, and so we did. We went citywide instead of just focusing on downtown in that first year. And then in July of 2022, we expanded again, covering the hours of 8 a.m. to 8 p.m. And we had a second location. So I think most of you probably know that the city of Madison absorbed the town of Madison. So we acquired the old Town of Madison Fire Station on Fish Hatch, and that is the second location for the CARES team. And now we can reach a wider geography more readily with a lower response time and more efficiently, and for more hours of the day. And you'll see the impact of that in the data. So when staff get into the presentation, you can actually see each time we expanded service, we were able to reach more people, and more people were in fact served. And we continue to see that impact grow, not just in the number of people that we're serving, but also in how they are served. And a lot of times folks are receiving crisis care without needing to be transported anywhere. And that means that people who are experiencing anxiety, depression, issues with drug and alcohol use are being touched by this program and helped by this program. They've been connected to all sorts of services, from crisis lines to residential and day shelters to emergency rooms to detox facilities and more. In the coming operating budget, we will be expanding our service hours for CARES again to include weekends, and planning, that'll be by mid-year, and then planning for a third team starting in October of next year. And that's because, we believe in this service. The data suggests that there's more need out there, and, frankly, people are utilizing the service, so there's a demand, and we need to meet that demand. There's a lot more to learn about the impact of CARES, and we want to hear also about your thoughts and experiences if you've had an interaction with the CARES teams. But I did want to just start by acknowledging how we got to where we are today, and also by acknowledging that we did that in partnership with many people who know and care about this work. And we did it with intentionality, really trying to stay focused on centering patient care. So a huge thank you is owed to the early pioneers of this program, including Assistant Chief Chase Stedman, who you'll hear from, Sarah Hendricks of Journey Mental Health, and our partners in the county's Division of Mental Health. I also want to recognize former Alder Arvina Martin for her work to make CARES a reality, and retired Fire Chief Steve Davis for his leadership on CARES. And special thanks tonight to Matt Scanlon, who wrote this end-of-year report on behalf of our partners at Public Health Madison and Dane County. Thank you all for being here tonight and for staying engaged with this project. And I hope that we can continue to work together with leaders across the city, county, and state to strengthen the entire mental health landscape for our community, including continuing to grow CARES. Thanks, Ruben.
Thank you, Mayor, for those words and for your leadership on this. And so now I get to bring over Assistant Chief Chase Stedman to lead us into findings of the report and tell us how we got to this point in the first place.
All right, thank you, Ruben, and thank you for your words, Mayor. We know from looking at national statistics that the need for mobile crisis response is clear, right? Behavioral health crises such as suicides and drug overdoses have been rising across the country in recent years. And, we also now have a decent understanding of all of the risk factors for behavioral health crisis, such as job loss, depression, social isolation, serious illnesses, substance abuse disorders, and barriers to healthcare. And in many ways, the COVID-19 pandemic really made these risk factors a lot more salient and compounded them and their negative health effects. So, given the rise in the trend for behavioral health crisis and the additive effects of the pandemic, there is certainly a pressing need to improve services for behavioral health crisis, and not just in the 911 environment, but in the community and many other areas as well. So, the one such improvement is the implementation of our mobile crisis response team, or the CARES team. That uses, specifically trained folks in addressing behavioral health crisis in the field. Research does indicate that mobile crisis response teams like CARES that can help de-escalate a crisis, connect patients with the appropriate behavioral health care in the community, and offer more opportunities for deflection and diversion from ERs and from arrests is certainly most patient-centered. And so this is our way of transforming Madison's crisis service system with this implementation of this program. Next slide. So just to give you kind of an overview, what is CARES? It's a team that responds to nonviolent behavioral health emergencies in Madison. We also respond to check person or check welfare calls, which are, when a caller requests 911 to send an agency to just check and see if someone else is okay. That's oftentimes was a police response, but now CARES can respond to behavioral health emergencies and check welfare calls as an alternative to police. And it's it's really a true governmental partnership between public health of Madison-Dane County, the fire department, Journey Mental Health, all of our community providers, Dane County Human Services, the Dane County 911 Center, and the list goes on. But what are behavioral health emergencies? Like why do we send CARES to certain things? So it's typically suicidal thoughts, depression, anxiety, agitation, confusion, isolation, intoxication, and any other behaviors or thoughts or emotions that are unusual for somebody and causing distress. Who responds when CARES is called? I think we mentioned, right? It's a paramedic from the Madison Fire Department that's specially trained in crisis response. And most importantly, it's a crisis worker from Journey Mental Health. And they respond in a fire department branded SUV. And how do you request CARES? Well, it's simply by calling 911. If you or someone needs a CARES team, call 911 and you can just ask for CARES. But it's the 911 center's job to kind of talk through a protocol of questions to make the determination of whether or not CARES is appropriate. And so if you ask for CARES and you give them the information that it's a nonviolent behavioral health emergency and CARES is available, CARES is going to get sent. But please understand that if CARES is on other calls or they're not in service, it's going to be a police department response still. So when and where is CARES available? Currently, CARES is available citywide, and it's from 8 a.m. to 8 p.m. Monday through Friday. And most importantly, what types of services does CARES connect patients to? And it's a wide variety, but predominantly it's things like peer recovery coaches, case management services, the Aging and Disability Resource Center, recovery and rehab centers, shelters, detox facilities, psychiatric facilities, and counseling service. That's a non-exhaustive list, of course. Next slide. And the goal is really just the fact that each response is unique and it focuses on the patient. CARES calms situations, identifies patients' needs and concerns, treats those that they can treat on scene, but when needed, CARES can refer and transport patients to other services and really provide a warm handoff to that appropriate resource in the community. Next slide. So, Journey crisis workers and MFD community paramedics are dispatched in pairs. As we said, they carry radios for communications. We communicate on the fire department channels. Currently in operation from 8 a.m. to 8 p.m. But the two teams are working 10-hour shifts. So CARES 1 will work 8 a.m. to 6 p.m. CARES 2 works 11 a.m. to 9 p.m. We give them that hour at the end of the day to finish up their patient charting. So we have 12 hours worth of coverage with two teams that are both in service during that busiest time in the middle of the day. And of course, responding anywhere in the city of Madison. Next slide. So dispositions, the term dispositions for our purposes means the outcome or the resolution of the call. So the team has the autonomy and the flexibility to determine the appropriate resolution, right? They can transport people anywhere that they need to be transported, where they can receive the best help. And that's very different from a Madison Fire Department ambulance. The 9 ambulances that we do have, they can only transport to emergency rooms. So even though we might know a person might be served better at an urgent care clinic or a facility that has mental health professionals, ambulances can only take people to ERs, and law enforcement have limitations to where they can transport as well. So the fact that CARES patients can be taken really anywhere that's going to suit them best is really important. They can provide support just via the phone. If somebody just wants to talk, phone call only is appropriate. They can transport, even to a person's home. If that's where your support network is at home, we're happy to take you there. But they may assist the patient in connecting with other services like we mentioned. And we like to be able to follow up with folks to make sure that the referrals that we've made, that they're still following up with services, and to see how the people are doing on a check-in. And if needed, the Journey Crisis Unit can become involved if an emergency detention evaluation is needed as well. So let's get into the annual report a little bit. The data that you're about to see is from our first year of service. So it's from September 1st of 2021 to August 30th of 22. And during that first year, we responded to 935 calls. And as of today, CARES has responded to a total of 1,490 calls. So just taking a look at the types of behavioral health crisis and some of the percentages that we see, you can see it's pretty well spread out with suicidal, homicidal thoughts, agitation, alcohol use being some of the higher ones. And you can see that the other behavioral health concerns at 23%, that just goes to show you how broad the scope is of what our CARES team could be seeing. It really does end up being these folks, especially the journey counselors, are expected to be the jack of all trades when it comes to engaging in a mental health crisis. So we're certainly happy to have them as a partner. Next slide. So the challenges that patients report, people experiencing these sort of behavioral health crises often have underlying challenges that contribute to their crisis and their overall well-being. So for example, 52% of CARES patients report at least one of the challenges listed on this chart here, with the 2 most common being housing insecurity and substance use. Next slide. So the CARES program, is one type of behavioral health service within a much larger system. There are many behavioral health services in the Madison area that reach the same population. So among the 724 patients that CARES made contact with in its first year of service, 78% had an existing connection to at least one of the following behavioral health related services on the chart. So Journey Mental Health Services is the most common of the pre-existing service connections for CARES patients. And that's why it's really important to have that Journey Mental Health crisis worker there on scene. They can open up their laptop, they can see if a person has a care plan, if they have, what their history is. And so we can really understand the best path forward for them. Next slide. And so about a third of the CARES patients have been, let me step back. So now that the CARES program has been in service for a year, there has been sufficient time for people to be served by the program more than once. So among the 724 patients CARES made contact with, about 35% have been served by the program 2 or more times. So CARES itself is actually becoming a pre-existing service connection for about a third of its patients. Next slide. So just looking at some trends in CARES responses over time, Mayor Rhodes Conway kind of mentioned the programmatic expansion of CARES. We started September 1st of 21, opened up citywide service a few months after that. And then in July 25th of this year, we have 2 full-time teams, which we mentioned. But go ahead and go to the next slide, Matt. So this just shows you the trend over that first year of those 935 calls, averaging about 78 responses per month. And on average, the duration between when the call was dispatched and when the CARES team cleared the call was about 59 minutes. So just 1 minute short of an hour is about how long on average these calls are taking. And that doesn't include all the additional administrative time associated with the calls, the charting and everything that comes after that. And when CARES teams aren't actually going on calls, besides doing all of their charting of the electronic health records, they're out coordinating with other services and doing outreach and continuing the good work that they're doing in a non-911 situation. Next slide. So this is just kind of an alternative way to look at the same data by assessing the number of responses per days that the CARES program was in service. We're not in service 7 days a week, right? And there are times when the team is out of service, not just because it's a weekend, but they're not in service on holidays right now. Obviously, there's some vacation time, sick days, and training days. So, unfortunately, we're not in service every day at this point. But across the entire first year, the program averaged 3.8 responses per day. But since the service area and the hours have expanded, in August, we were averaging 8.3 responses per day that they were in service. So, the team is certainly getting busier as we put, more resources out there. They're catching more calls, which is clearly obvious from the data. Next screen. So looking at among all of the CARES responses, about 19% of them involve checking on the welfare of a person. So, when a friend or neighbor or family member or other concerned individual calls 911 to have someone check on the welfare of someone, the 911 center can send police or CARES, depending on the situation. But, if you haven't been able to get a hold of somebody for a number of days, you might call 911. And if you call 911 and say, hey, I'm just concerned about my grandma, I haven't been able to get a hold of her for a few days, that's going to be appropriate for CARES. And since the start of the program, a little less than a quarter of those 935 total calls, have been a check person or check welfare. And when we look at the next slide, you can kind of see that the trend of check welfares goes up along with the trend of normal calls for service. And the next slide is an important one for me. So go ahead and go to the next slide, Matt. Among the patients that CARES made contact with on those check welfare responses, 54% of them presented with behavioral health concerns. So that means that in the past, those concerns may not have been addressed appropriately, but now we're able to, not just go check and make sure the person's okay, but we can address these other underlying behavioral health concerns that they have. And for the impact of CARES, I'm going to transition over to Sarah Henriksen from Journey Mental Health. It's all yours, Sarah.
Great, thanks, Che. So moving from talking about primarily the creation and development of CARES and the data that we've collected on the operations, we want to talk now a little bit about how that has had an impact on the patients that we've served. Next slide, please, Matt. So we can see that the majority of CARES patients are being met in person in the community by the CARES team. As we talked about before, they have a lot of discretion and autonomy about how they handle the calls that they're assigned to. And particularly because they're now getting more calls for people that they've served in the past where they may have some previous knowledge of, it makes sense that there would be times that they would discern that the person might be best helped by a phone call. Like, I have some familiarity with this person. I know that they probably just need someone to talk to them for a few minutes or remind them of their care plan or something like that. And we don't need to kind of go out into the community and respond to them in person. That might be excessive to what their needs are in that moment. So there are some calls that are just handled that way. And there are some patients who, when CARES arrive, they might say, I don't need help or I don't want help and decline to engage with the CARES team. But as you can see by the two bars in the middle, the majority of people, they're serving in the community. They're providing a service of de-escalation, supportive listening, connecting people to appropriate resources, which may not involve taking them anywhere at all. So they may be providing support on scene, meeting the need of the patient and disengaging. And then in some cases, they're transporting them somewhere, and we'll talk more about that in a second. On a few calls, they're on a small number of calls overall, they have transferred the patient to another EMS agency. So basically, a patient who has medical needs beyond what they can manage, such as somebody who is not ambulatory or requires, to be in an ambulance and a gurney instead of being in the back of an SUV car if they don't have the mobility to be transported that way, or if they have more acute medical needs than what the CARES team can manage. And also in 3% of cases, patients have been transferred to a law enforcement agency, typically Madison Police Department. And those cases have primarily involved incidents of individuals who are in an acute behavioral health crisis and need a higher level of care and are not willing or safely able to access that care via a CARES team transport. And so police are called in to place them in protective custody to get them to the care that they need. Next slide. So of the patients that are transported, we see that the most common destination is an emergency room. Certainly, one of the goals of the CARES team is to divert people, not just from unnecessary law enforcement contacts, but also from emergency room care when that's not needed. But there are a number of times when that is still needed, either because the person is in a very acute crisis and needs to access emergency care, or because the resources that might help to resolve the issue in the field are not accessible or are not available at that time. And even in those cases where patients are being, where their needs are not being able to be met in the field and they're transported to a hospital, we're still, we're providing the service of bringing people to seek behavioral health care without having to be in police custody to do so. And that is just a comment on what is the most appropriate way to respond to behavioral health crises. That even the most well-trained and empathetic police officer is still a uniformed armed police officer with driving a squad car, which may not be the most appropriate or least traumatizing way to get that patient to the care that they need. Next slide. Oh, and I apologize on that last one. I also just wanted to mention that I think there was an article that just came out in the State Journal the other day about the delay in getting the Crisis Restoration Center going in Dane County. And this is something that we also see as a really key piece of the continuum of care that CARES is a piece of. In other communities that have a CARES type program, many times patients, instead of being brought to a hospital emergency room, are brought to a crisis triage center or similar type of facility to have if their needs can't be met in the field, but they don't necessarily need to go to a hospital. So of the patients that were referred to services, a really common service that people are being referred to is a crisis line. We have a 24-hour crisis line at Journey Mental Health, and sometimes people call 911 because they don't know where else to call. They don't know how to get help with their behavioral health crisis or what's the appropriate resource. So even just to give people a number that they know that they can call 24/7 and speak to a person who will provide support and listening and help connect them to services if needed is a critical piece of providing connection to the care that they need. And then, as you can see, and a number of other types of resources that we're connecting people to as well. There may be some patients who don't need connection to resources because they already have services that they're involved with, or perhaps the nature of the CARES call is just that a person is having a crisis moment. They need some support at that time, and they don't necessarily need to be referred to ongoing services. Next slide. So one of the things that's been a little bit challenging in terms of looking at the data of the number of potential CARES calls for service is that the 911 center software or electronic record does not have the capacity to just mark calls as CARES appropriate, not CARES appropriate. And so we kind of have to extrapolate from the data that we have available to us. So we don't have an exact count of the number of calls that CARES could go on, but is not going on. What we do have is data from 3 years of Madison Police Department data from 2018 to 20, showing the average number of behavioral health related calls for service per day and per time of day and days of the week and things like that. That data was used to inform when and how we launched CARES in the community to best meet the need. And it also helps us see the impact that the CARES team is having. So we can see that in terms of behavioral health related calls for service, based on that data, we can estimate that CARES is meeting over half of those calls that would occur during the time the team is in service. So not all the calls that occur 24/7, but during the time that they're in service. And then in terms of the check welfare calls, again, it's a smaller percentage. This is such a broader range of type of calls. And the number that the CARES team has been responding to is smaller, but I think that's also something that we anticipate growing, particularly as we continue to expand.
All right, Sarah, I'll take back over for you for our last two slides. So just some key takeaways for you to hopefully generate some more questions. So CARES responded to 935 total calls for service, with each response averaging about an hour. And we made contact with 724 different individuals among the 935 calls. CARES responded to 57% of the estimated number of mental health calls and 9% of the daily average of check welfare calls that occurred in Madison during the time that we were in service. Only 3% of the CARES patients have been transferred to police, and that indicates for us that CARES is meeting its objective at this point to divert patients from police when possible. And CARES teams only transported 18% of the 724 patients it made contact with to emergency rooms, like Sarah mentioned. And this indicates that CARES is, starting to meet that objective to divert patients from emergency rooms. Although we still do use them, we're doing a better job than previously. So the last thing we would just want to mention is our next expansion. If you can go to the next slide, Matt. So the mayor's executive budget included for 2023 one more crisis worker and one more community paramedic, so that we can open up weekend hours. We really do obviously see a need to be at least 7-day-a-week operation. We understand that things happen on the weekends that we haven't been able to capture before. So hopefully by the end of March of 2023, we will have teams in service also on Saturdays and Sundays. And then October of 2023, plan to hire one more of each specialty, and then have a third team working during those peak hours during the week, so that we can hopefully capture more of that kind of, that whatever 43% that we're not capturing at the current time. And now the most important part, questions. It's all yours, Ruben.
Thanks, Chief Stedman. Thanks, everybody. So yeah, we're going to go into Q&A right now. But before we do that, I want to go to the next slide and just remind everybody, thank you for people who've already submitted questions. You can continue submitting questions while we go through this. Again, our goal is 7:30 for an end, so we might end a little bit early tonight. But if you go to the bottom of your screen, there's a Q&A section. And like we said, we're going to try to, if you have the same question as someone else, we might try to combine those questions. But I'm going to open it up to the group now. And at the end of this whole program, we will show you contact information for myself, for Sarah, and for the chief, in case you want to reach out to us. But if you want to end the slide, and then we can bring it up to the general group and have Kara start going through some of our questions.
Sounds good. Thank you, Ruben. I just want to encourage folks to submit those questions in the Q&A, and that I'm not going to read personal experiences, but we'll focus in on the questions. So the first question is, have there been consideration of a separate number for the CARES team in addition to 911?
Yeah, that has actually come up a number of times, and I don't know what's going to happen down the road, but all I can say is that this team was developed as a 911 resource. That was the purpose behind it. We've had people ask about, boy, do you have just a 1-800 number or somewhere we can call where it's not to 911? And really the model that we are trying to enhance here is the 911 responses. And we're trying to help the police department out obviously trying to get patients the most appropriate care, the right intervention at the right time in a 911 situation. So as of right now, we don't have plans for any other numbers because we want to be a 911 resource.
Thank you, Shay. The next question comes with a little context. With the pandemic, there seems to be a growing number of doors to help people struggling with anxiety, depression, suicidal thoughts, isolation, and or drug and alcohol use. A few examples might include our national 988 suicide crisis line, mobile phone apps, and social media. Do you have insights on how these doors could help perhaps support or partner with CARES?
Sarah, can you take that one?
Sure. So prior to 988 launching, the National Suicide Hotline calls were routed to local call centers. So the Dane County Crisis Unit, part of Journey Mental Health, was the recipient of local calls to the 1-800 suicide hotline. Now with the advent of 988, those calls are all going to a call center in, I believe, in the Green Bay area of Wisconsin. And so we're not fielding those calls at Journey anymore as we were. And when folks on the 988 call center are receiving calls from people who are located in Dane County or other communities, they're trying to connect them to resources there. So I don't know exactly how the interface is happening between 988 and our local 911 center, but I would imagine that if an emergency response was generated by a call to the 988 center, that it could be CARES or police who would get dispatched based on the nature of the call. And in terms of, social media apps and things like that, I definitely, we need to embrace kind of the way the world is going and find ways to do that at this point. I think that's only happening indirectly, like when people are contacting a suicide text line or some other website or posting things on social media that are concerning that might cause someone to call 911 and request that the person be checked on.
Thank you for your insight, Sarah. Our next question from an attendee asks an example of, if I cut my finger and I need stitches, would CARES transport me to urgent care?
No. So if you cut your finger and you called 911 because you cut your finger, that is, the 911 center would see that as purely a medical call, and they would send fire department paramedics. So you get an ambulance. Paramedics don't do stitches, and unfortunately, they can't take you to an urgent care. That's just the model that we're in. I understand, we talked about CARES having the ability to transport people anywhere they need to go, but it's really surrounding their behavioral health crisis, not other sort of medical reasons.
Thank you, Jay. We have some potential community partners on the attendee list asking, we are listening from Clean Slate, an outpatient mat provider. How do we become a partner for the CARES team to refer to?
Well, I think I've actually had some contact with an individual from that organization and that we are planning some follow-up there. So definitely that is something that we are interested in. And as Che said, kind of networking and connecting with service providers in the community is a big part of what CARES does. In fact, when the first team was hired a couple months before they officially launched, they were doing a lot of outreach and networking, really trying to get to know different area service providers, to introduce themselves and let them know that CARES was going to be active, but also to learn more about the resources that they might connect people to. So I receive a lot of contacts from a lot of different places who are wanting to be on the radar for CARES and other crisis response, to just let people know that these services are available. So definitely receptive to that information and that kind of partnering.
Thank you, Sarah. There will be contact information shared at the end of our Q&A, so I will make sure that you all see that before we wrap our Q&A. The next question asks, what does the CARES vehicle look like? Do we have something we could share on screen?
Yeah, I don't know if Matt will be available to share one, but I can tell you it is a fire department branded SUV. So it's a Ford Explorer that has that's red like a fire department vehicle and has fire department logos on it. So it'll be very obvious that it's a fire department vehicle.
I would welcome if we have an opportunity to share a picture to come back to that. So I'll just plug a pin for that. But for now, I'm going to continue on. What is the likelihood? Oh, here, let's pause for a minute. There it is. Thank you for sharing that excellent image for our education. Appreciate that. The next question is, what is the likelihood of expanding this program to the Madison suburbs soon?
Yeah, so if the question is about expanding outside of the city of Madison into Dane County, we're having a lot of conversations about that right now. And I can tell you that, the vision, years, 2, 3, however many years it takes us to get there, the vision is to have a 24/7 countywide multiple response teams. And whether that is through the Madison Fire Department and Journey Mental Health partnership, or if it's other EMS agencies in the county, along with other providers, one way or the other, we hope that this is going to be a countywide initiative in the years to come. A lot more to come on that. We're having conversations, not just with Dane County Public Health, but Dane County Human Services, the county exec's office. So yes, we expect this sort of programming to be expanded out into the county.
Awesome. Thanks, Jay. I do just want to reiterate that things coming into the chat with lengthy stories, I will be pausing on and encourage folks to consider our follow-up contacts for specific details on specific scenarios. The next question is, will I be billed for CARES services?
No, the fire department does not bill for these services, and that's why we're able to kind of really transport anywhere. Our ambulances bill insurance and Medicare and Medicaid, and that's why they can only take people to emergency rooms. But no, the city of Madison and the fire department don't bill.
Well, thank you. Our next question, when a person needs a crisis line, is CARES able to transfer the call rather than giving out a number?
We do, sorry, Sarah, if you want to handle that, but we don't have the ability to transfer. The CARES team doesn't have the ability to transfer, but I think Sarah can speak to the possibility of the 911 center being able to connect them.
Sometimes the 911 center will transfer a caller to our 24-hour crisis line if that seems to be the appropriate way to meet their need, particularly if it's outside the CARES service hours, or sometimes they've sent us callers who are clearly just needing someone to talk to, needing a crisis line and weren't sure where to call. Sometimes we've talked to people while emergency responders are heading out, any number of different things. But the CARES team is dispatched over the radio by the 911 center. So there's not a phone call that they're taking that they're transferring to someone. I'm wondering if this might be a reference to the piece that talked about referring people to crisis lines. So this is not CARES getting a call from someone and saying, oh, here, talk to this crisis line instead of us. This is CARES providing a service to a person who's in a crisis and then giving them a crisis line as another resource that they can utilize in the future.
Thank you, Sarah. Our next question asks, has there been any discussion about incorporating peer specialists on the team, which is assigned with the CAHOOTS model? Can CARES partner with MMSD to deal with behavioral health issues that arise in our schools rather than police being utilized? Two separate questions. Sorry about that.
So to start with the first one, yes, we've been talking about peer support specialists since way back in the beginning. And we know that this is a really integral part of crisis response teams like CARES and others in other communities. And this is something that we want to be part of the CARES team as well. We do have peer support specialists involved in every level of crisis services and other services at Journey Mental Health. We've not taken that step yet to have peer support specialists embedded in the team or being part of the CARES team yet, but I do anticipate that that's something that will happen in the future. In terms of partnering with MMSD, I wouldn't say that we have any kind of like, a formal partnership for CARES responses, but CARES can and has responded to schools just like other emergency responders would. So I think there's a recognition in the school district that this is an alternative that could be sent to respond to a student who's in crisis. And that may be something that they request when they call the 911 center. But I think that's about as much as I could comment on that piece at this point.
Thank you, Sarah. Next question. Can callers reject police intervention if a CARES team is not available?
I'll try to speak to this as best as I can. The Dane County 911 Center it isn't in the fire department, right? They're a separate entity, and so I might not have the most insight, but I do know that people have called 911 and asked for CARES, and the 911 Center has told them CARES isn't available right now. Would you like police to respond? And as long as and the person can say no, but if they're reporting something that it's kind of 911 has to send somebody for certain things. And I'll just kind of leave it at that, Sarah, unless you want to add to it. Like you can turn it down, but not under certain circumstances, right? So if somebody is acting suicidal, they've got a plan, right? And you're like, but I don't want the police department to come. There's a line where we have to say, listen, we need to send somebody. So it really depends on the call type. Sarah, I don't know if you want to expand on that.
Well, I think also sometimes when somebody is concerned about a loved one who's in a crisis, they might be concerned that police coming on scene is going to escalate that person. If they have a negative history with police, or just the fact that law enforcement is triggering to them in any way, or they're afraid that their loved one is going to be arrested or hurt by police. So there certainly could be times where someone might call and say, my loved one is escalated and engaging in a way that is, very dangerous, but I don't want police to come because I think it's going to get worse. And we have some flexibility in terms of, sometimes police might go and secure a scene and then bring CARES in. They might request CARES over the radio, or it might be kind of a co-response where police are making sure that things are physically safe before CARES engages the patient. But ultimately, we have to start with safety, make sure that people are safe, including not just our teams, but the people they're responding to, that they may not have the tools to respond safely to. When people call the 911 center and say, I'm in a crisis, or I want someone to be checked on who's in a crisis, and the CARES team is not available and they don't want police, we've encouraged the 911 center to transfer their call to our crisis line, which is 24/7. And that way we can talk with the individual, try to figure out what's going on, whether it requires a mobile response, or if there is some other way that we can be planful with them to meet the patient's needs, to make sure that that they're getting the resources that they need, and that safety is ensured.
Thank you, Sarah. Our next question asks about, it was mentioned that the lack of crisis triage center is a gap in the continuum of care in the city. Is there a simple document that identifies the pieces of our continuum of care and identifies the gaps needing to be filled?
A simple document? I don't know. I know there was a whole report that the county did a couple of years ago when they first started studying doing a crisis restoration center, that really maps out all these pieces. And it is not a simple document. It's very lengthy. And I don't actually, off the top of my head, have a link to it or something like that, but we could maybe try to get that out to attendees later.
Yeah, and I would also just say that there really isn't anything, unfortunately, simple about the Dane County services either. We've got a detox facility, for instance, but there aren't always beds available. So CARES or police have to call detox ahead of time to see if there's beds available. And so, it's not just that we don't have a 24/7 triage, mental health triage center to take people to. It's the fact that, the hospitals can do some really good work with mental health and psychiatric patients, but they have limited resources in those facilities. So it's about the number of beds, and it's about how we're connecting. And there's Dane County, I think most people look at Dane County and think, boy, it's very resource rich, right? A lot of social services, but it's making all the connections and having all of those services be available at the right time for the right person that gets really difficult. But that 24/7 behavioral health triage center will certainly be a big help for all of us.
Thank you. I want to acknowledge some interest in additional data, and we will have the slides available at the end for you to have staff contact information to ask more questions and specificity that you're wondering about. The next question is, can you talk about the expansion of CARES to all of Dane County? We talked a little bit about that. What would it look like for the CARES team to work with multiple police, fire departments across the county?
Yeah, I can just say that the possibility is there. It's just going to take a lot of funding. The Madison Fire Department would need to hire a lot more community paramedics that were trained in this type of work, and Journey Mental Health would need to hire a lot more crisis workers, right, for us to cover the county 24/7. And the thing to remember too, it's not just the boots on the ground workers, it's all of the structure around them and supervision and data evaluation and program evaluation. There really is a big ecosystem to make programs like this work. It's not about just, hiring a couple of folks and sending them out on the streets. If you want to do it right, there really is a lot of support needed. So I think the unfortunate answer is money is what we need.
Thank you, Che. I do just want to make a comment. Thank you to the anonymous attendee who alerted me that my answering questions in the Zoom does create a count and is sending those into a place that's publicly visible. So I'm not going to necessarily move any more questions into that answered column for the sake of protection of privacy. And I just want to acknowledge that you will not see that answered question count increase any further, even though we will continue to take questions. So the next question I see is, how will the two positions in the Dane County budget, one for 911 and one for Human Services, help with the countywide expansion of CARES?
I think I can speak to that a little bit. So at the 911 center, the move with them is to try to get a behavioral health clinician in the 911 center to help triage calls. And the reason for that is it when you look around at other programs around the country, that really is one of the best practices out there is to actually have somebody in the 911 center that can act, as Sarah was mentioning, as kind of that crisis line. And then they can use their expertise to triage the call to the appropriate resource. I believe the other position is just to evaluate how best a program like CARES could be placed in the county, placed in Dane County. So, again, Dane County can't just hire some folks and throw them on the streets. They need to evaluate, that there's a lot of communities that are very different from Madison. And we had to develop our program around the needs of the city of Madison. And I can say one comparable that's very obvious is that, there's about 35 EMS districts in Dane County. A lot of them are volunteer. And so those small agencies can't support a crisis response team with community paramedics and everything else. So the model in Madison is a good one, but it's not a one size fits all. So I believe that Human Services position is to evaluate what it should look like in the county.
Thank you, Che. I want to note that there are incredible kudos coming to all of these experts in this room into the Q&A, and just want to verbalize that to you all. The next question is, after piloting this program for over a year, what do you see as the greatest need for filling the gaps in the behavioral health crisis system?
I personally think we already talked about a little bit that 24/7 behavioral health triage center where folks can be brought to and receive the treatment and the care and the interventions that they need somewhere right here in Dane County. We just don't have it.
I would second that and also say that I think that we're resource rich in Dane County in the sense that we have some really amazing programs and services here. but that it's a quantity, not a quality issue, that we don't have enough services for the people who need them. And when we see people who are maybe not in a super acute crisis, but are very much needing help, or maybe have needed help for a long time and have finally decided to seek out that help, which is a huge decision for a person to make, and they can't access care quickly, or they get put on a 3-month wait list or things like that. I mean, we're scrambling to provide case management and outpatient services to people that are coming out of hospitals after being detained. And what about the people that we're trying to prevent from even getting to the hospital in the first place? So again, really want to emphasize that I think we have a quality of services here and providers here, and some really amazing programs and people that do really good work here. And there's just not enough of us.
Thank you. I'm going to paraphrase the following question. I'm not sure that you can answer it. It's about trade-offs with Dane County affording to build a jail compared to the effectiveness and cost efficiencies related to alternate programs like CARES.
Yeah, I'm certainly not an expert in that area. Haven't studied it enough to answer that one intelligently. Sorry. I can give you my thoughts, but I don't think that matters. Sorry, Sarah, go ahead.
No, I was just going to say, I think there's questions about where money comes from, right? So the funding for CARES has to come from somewhere. And so when you have competing interests in the community, competing needs, adequate policing levels, a jail, all the service systems that I just talked about that are so underfunded and understaffed, I really encourage people not to think of it as like a zero-sum game. Like, if we're going to have CARES, then we have to take from something else. Let's really focus on gathering the resources to support all of the things that we need.
Thank you for that, Sarah. The so far last question, just flagging for the audience, if you have any more, shoot them my way. What is a community paramedic?
Great question. So the Madison Fire Department has had community paramedics since around 2015. There's quite a few different models out there, but community paramedics are essentially paramedics that have normally worked in the 911 arena, right, responding to 911 emergencies. They get specially trained in a lot more of like a social work type role, and that's the easiest way I can explain it. It's about sending these paramedics out in a non-911 situation to visit people that are, for instance, frequent users of the 911 system. They need healthcare system education. They need to have their discharge paperwork from the emergency room explained to them. They need to have medication reconciliations done in their home. So it's really kind of like a mix of home health and social work, and getting into people's homes in non-emergent times so that they can help educate them and provide them services and referrals. So community paramedics aren't only for crisis response. They're for any number of community risk reduction initiatives in the community that aren't during a 911 situation, right? So it could be doing opioid education, handing out fentanyl test strips. It can be teaching CPR in the community, really anything that helps the community in their risk assessment and what's needed.
Excellent. Always exciting to learn about more services in the fire department. Would the CARES program benefit from a wheelchair accessible van or partnership with an accessible transit to reduce the use of EMS transports?
Yeah, so we have so our ambulances, have the ability, obviously, to transport people that are not mobile, but we oftentimes run into issues with people having a large mobile wheelchair, electric wheelchair, if you will, that we can't take with us. And so we have services that we can call in. Madison Metro is one of them, but there's other services that we have for transportation of large wheelchairs or any other sort of equipment that needs to come with people in an ambulance. But so we do have some resources available to us just as a city agency for transport. But yeah, that's one thing, using a fire department Ford Explorer SUV does offer some challenges with certain patients that have mobilization issues.
And that metro service is called paratransit services,
Oh, yeah.
in case you were curious in the public. Okay, the next question. Have you considered community partnerships through private funding to increase the expansion of CARES? This attendee suggests that's how Cahoots model their following funds their program.
I mean, are we going to decline private money? No, I really don't know if anyone has actively explored that. I think it's an interesting, especially given my previous comments about the fact that, we don't want to take from one thing to fund another thing. I'm a social worker, not a fundraiser. This is not my area of expertise, so I'm going to bow out of that discussion.
Yeah, and I certainly think that's a bit above my pay grade as well. I don't tend to go out and look for the funding sources as much, but I will tell you that we do have a Community Paramedic Foundation, a nonprofit that we take donations through because our CARES teams have a slush fund so that they can buy people things when they need them. We don't like to promote that a lot because we don't want people calling us up so that we can buy them cigarettes, of course, but we will buy things for people that truly need them. And that includes like an air conditioner unit for their small room that they're in that's super hot in the summertime. It includes clothes. So those are the small things so that we have petty cash to provide things for people. But, I know other programs do look at like insurance companies saying, hey, we're saving, or hospital systems, right? We're saving big systems money by channeling people to the right areas of the healthcare system and of the mental health care system so that people aren't using ambulances and ERs for all of these things. So yeah, I personally will tell you that I think insurance companies and hospital systems, it would be nice to see some money from them.
And I'll nudge if you have a lead on a funding source that I'm sure Deputy Mayor Sanon would be grateful to have you send an email as follow-up with that lead. Our final question that I'm seeing right now is, how can the community support this work or advocate for the decriminalization of behavioral health issues? Who should we be talking to, or what should we be doing?
I would go back to what I was talking about before in terms of the need for really well supported services in this community. We have, when people are not getting their needs met, that's why they are coming to the attention of emergency responders. Mm-hmm. So I think we are absolutely moving in the right direction by bringing a more appropriate resource to a person in a behavioral health crisis. But if we could prevent more of those crises from occurring so that people are less likely to have 911 calls about them or that they're calling, and less likely to have, whether it's CARES, police, or whomever, when we're looking to decriminalize mental illness, we need to treat mental illness and substance use. We need to provide people access to the care that they need so that they're not in crisis, so that they're not having these contacts with emergency responders that may, even if we had the capacity to respond 24/7 countywide with CARES, we would not respond to every behavioral health crisis that occurs. And so if we can minimize the crises happening in the first place by adequately funding the resources that people need to get the treatment and stabilization that keeps them out of crisis, that would be my vote.
Anything else from you, Che?
Oh, if you live in the city of Madison, you have an alder that you live in their district. They're part of the city council. You talk to them about what they're going to be voting for.
It's amazing to see so many brilliant folks on this call talking about an amazing service in our community, and so many of you joining us this evening to ask questions. I have one final one that just popped in. It seems to me this question is effectively similar to one we've already asked about the trade-offs between the jail and the zero-sum games. So I'm not going to go back into that at this time, but will think that that would be all I can do at the moment is turn it back to you, Ruben.
Thank you so much, Kara. I want to say a genuine thank you to the team who was here tonight, Sarah and Shay, and of course, Matt Scanlon for putting this report together. And thank you all, residents and beyond, apparently, which is great, for being here and asking these really important questions. So if Matt could actually bring up the slide with our contact information on it, you'll be able to reach out to Shay, Sarah, and I, but I'm the contact in the mayor's office. And so thinking about that funding, that advocacy, or any other feedback you want to give about CARES or the city in general, this is a great place to reach out to me, Ruben Senon, here in the mayor's office. And of course, a big thank you to all the people that has made this possible at the county, at Journey Mental Health, and in the community and giving us feedback and advice. So I think that's it for tonight. If you have further questions that weren't answered, I think it's great if you reach out to me or Che and Sarah, obviously the stronger experts. And I guess we'll say goodnight. Thanks, everybody.
Take care.